Hi, good afternoon. I'm Michael Fehlings from the University of Toronto.
And I'm Dan Resnick from the University of Wisconsin. And Mike and I are going to talk a little bit about outcome measures in spine surgery. And Mike, why don't you sort of lead us off and maybe just explain what you think the most useful outcome measures are for cervical myelopathy, for example. You've given us a number of presentations on that today, and we know that there's a number to choose from. They have a varying utility, varying sensitivity, and what do you think the optimal outcome measures are when assessing patients with cervical myelopathy?
Sure. Well, I think that it's important for all spine surgeons to consider the collection of outcome measures in their practice. And this isn't just for research purposes. This is also increasingly important to document a value in the context of value-based healthcare. So in principle, one, I think, should consider collecting what's referred to as a generic health outcomes instrument. This might include the SF-36, which is a physical component score and a mental component score. So that's commonly used, and that has the advantage in that those scores can also be converted to quality-adjusted life years and can be used for health economics analyses. Another option would be to use the EQ5D, which has also been increasingly validated in spine surgery. And then, depending on the condition that you're looking at, you then want to look at what are referred to as disease-specific health outcomes. And these might either measure function, or they may measure disability or impairment. So in the context of cervical myelopathy, an outcome instrument that I would highly recommend that surgeons and clinics use is the Modified Japanese Orthopedic Association scale, or the MJOA. This is an 18-point scale. It's administered by a health professional after conducting an interview with the patient. It takes about 5 minutes to do, and it allows the classification of myelopathy impairment into severe, moderate, and mild. And then other outcomes that are commonly collected are some measure of walking. So a 10-meter walk test is commonly done where you time a patient walking 10 meters. There's a neuric score, which is a 5-point scale that's heavily weighted toward pain and independent walking. And then also for the neck, commonly a neck disability index is measured, which is essentially the cervical analog of the stress-free disability index.
So if, say, we're hypothetically constructing a registry to follow a large group of patients with cervical myelopathy, and we're really crunched in terms of the amount of data we can collect, because this is being done in it's not a research setting, it's a office setting with a relatively limited resources. What do you think would be the core group of measures that would be able to capture both the health utility measures and the disease-specific measures in as succinct yet informative manner as possible?
Yeah, so if I had two to choose, then I would choose the SF-36 just because it's so well accepted and the data are clearly interpretable. It may not always be the most sensitive for spine conditions, but the results are quite clear, and outcomes for myelopathy management have been shown to be responsive to SF-36 measurements. And then I would select the MGOA because it's been validated, and it's reasonably sensitive, certainly in the mid-range of the scores. It's not necessarily as sensitive for patients with very mild myelopathy, but it's probably the best outcome measure we have right now.
It's also probably the most easily understood
yes.
when you go through them.
Right.
In the lumbar spine, we really have the same issues. We try to use the disease-specific. Usually, the ODI is sort of the grandfathered in measure or legacy measure, but there's been a lot of interest in the PROMISE tool, which is a iterative instrument where you can apparently get much greater clarity of information with even fewer questions. I know that it's just recently been explored in terms of being validated in the lumbar spine. Literally, the publications were a few weeks ago. But is there anything like that in the cervical spine? Has anyone looked at the PROMISE in a cervical population at all?
Yeah, so the appeal of the PROMISE, as you've indicated, Dan, is that one can use one outcomes instrument that would encompass a number of generic and disease-specific measures, and is also iterative, and so that if a patient answers one set of questions, then they don't have to answer all the questions. They go to another a part of the scale. And it certainly, it's been validated for musculoskeletal conditions, and as you've indicated recently for lumbar spine. And there are discussions right now in terms of looking at this for degenerative cervical disorders, but those studies have not yet been undertaken, so it hasn't been validated yet for conditions such as cervical myelopathy.
And the importance of validation with a measure, obviously, is that if the measure isn't responsive to what you're trying to fix, it doesn't make much sense to measure that, and if it's not reliable, it doesn't make much sense.
Yeah,
so the
that's
validation
correct.
process is very important. In constructing the registry, we pretty much did the same thing as you described, using the oswestry as our disease specific, and we chose the EQ5D simply because it had fewer questions. And are thinking that less work for the medical assistant to fill out the forms more than anything else, and trying to keep everything on a one-page entrance.
We've had experience with looking at both SF36 and EQ5D in the context of metastatic spine cancer, and neither is particularly great in this condition, but there are subscores in the SF36 that are responsive. Right. But the EQ5D is a simpler outcome. It does measure somewhat different constructs in the SF36, but is generally felt to be similar. I would say that it's less well known in North America, but at an international level is quite widely used. So that's interesting that you've kind of switched going to this. We found in the metastatic spine study that we did through AO Spine North America that both EQ5D and various subdomains in SF36 were responsive to treatment of metastatic spine cancer.
It's good to the data that you've produced through those studies and that we're gathering are very valuable, not only for the data themselves, but showing that these instruments are actually useful. There's a lot of concerns with about ceiling effects and floor effects, and you mentioned that a little bit with regard to myelopathy and the MGOA to some extent. There being a ceiling effect, you can't be
for sure. So one of the challenges with myelopathies, ideally, I think. As myelopathy becomes increasingly recognized, and it's not recognized enough by the public and by general physicians, in my opinion, but I think increasingly we should be treating patients who are at a milder stage, or maybe between the mild and the moderate zones of the MGOA. And in general, these outcome scales are more responsive in the mid-range. Yeah. And as you say, get up to the 16 and 17 level, things blur, and you start running into ceiling effects. And also at 16 and 17, the MGOA may not always be sensitive enough to discriminate mild levels of myelopathy. So those are certainly some of the limitations. And I think one of the important things to recognize is that the development of these outcomes is not static, it's a fluid process. We have a changing demographic, we have an aging population, different socioeconomic groups, cultural groups, etc. will have different perceptions of all of these things, which can certainly change the way we use these over time.
Yeah, I really wondered about the utility of asking an octogenarian about her sex life on the oswestry when her husband's been dead for 20 years, type thing. But I do think we absolutely agree 100% that the important thing is to have a disease-specific measure and then some sort of health utility measure that for global health. NASA has published a compendium of measures that have been validated, and I think it's up to everybody. If you're going to, I think we would both agree that physicians should be measuring their outcomes. Using validated instruments, and depending upon what you're doing, select a disease-specific measure that makes sense for you, and try and include a global one, a health utility measure as well for health economic analysis going down the road.
Yeah, for sure. And I think that increasingly, as we indicated at the outset, this is going to be important not just for research purposes or just to as a general measure of one's own quality of practice, but I think increasingly we're going to be required by society and specifically by payers to demonstrate that we're hitting certain targeted outcomes. And so, collecting some of these critical outcomes will be very important.
Very good.